Okay, good morning, everyone. We are going to be talking about a rare bone sarcoma called Ewing sarcoma, named after a pathologist, James Ewing, who described it in the early 1900s. And it is a highly malignant cancer of bone that is the second most common bone sarcoma in childhood. So most patients that have a Ewing sarcoma are between the age of 10 and 15, although it can be younger, and rarely occurs in the age up to 40 or so, but 80% are younger than 20 years. It can arise in any portion of the skeleton and is occasionally in the soft tissues as well, but it's usually in the diaphysis of a long bone or the pelvis. There is a tumor that occurs in the chest wall that was described by Dr. Askin, and that's sometimes referred to an Askin tumor, but that's just a Ewing sarcoma that occurs in the chest. So you may be wondering what this is, and it's not an old record. Ewing sarcoma is one of the round cell tumors, meaning the cells that form it are round, not particularly distinct tumors that cells that with a central nucleus that all look pretty much alike. And there are many tumors that can look like a Ewing sarcoma. So this slide, most pathologists and certainly I cannot tell which of these is a Ewing sarcoma versus some other round cell tumors. And so what are the other round cell tumors? They can be a lot of things. You know, we're talking about Ewing today, but there are other tumors that can look like this, including a mesenchymal chondrosarcoma, which is obviously quite different. Small cell osteosarcoma, which is a tumor of small round blue cells that makes bone. Myeloma, a tumor of plasma cells, and lymphoma, a tumor of usually B cells when it's in the bone, can look like this. Langerhans cell histiocytosis, or what we sometimes in orthopedics think of as eosinophilic granuloma, can look like a round cell tumor. Leukemia, which is much more common than Ewing sarcoma when it involves the bone, can look like a Ewing. Rhabdomyosarcoma you usually don't see in bone, but under the microscope it can look similar. And although metastatic disease in children is much less common than in adults, occasionally you will get metastatic tumors such as neuroblastoma and Wilms tumor that can occur in the bone, and they are round cell tumors as well. And in older people, small cell carcinomas and rhabdomyosarcomas. So this doesn't really concern us as surgeons, but the pathologist has to sort all these different diagnoses out when he or she gets a biopsy. So what is Ewing sarcoma? It's a round cell, as we just talked about, sarcoma with some differentiation, usually along neuroectodermal pathways. But it's mainly a tumor when you look for various markers like muscle or other differentiators. doesn't have that. It's just undifferentiated. So it's almost like a diagnosis of exclusion. There was, for a while, a belief that there were neuroectodermal tumors that looked like that, called primitive neuroectodermal tumor, or PNET. We now know that because they have the same genetic translocation as Ewing sarcoma, that we think of these as the same tumors, even though they may look similar under the microscope. And so PNET is not now part of the WHO classification, although you may see that term. It used to be more prominent. So Ewing makes up less than 10% of all primary malignant bone tumors, but in populations studies, it would be a pretty uncommon tumor. And here you can see femur and the long bones of the lower extremity are common sites, as is the pelvis. And then we talked about the ones that occur in the chest wall. If you think about other malignant tumors of bone, osteosarcoma would be the most common, and many of the principles that we're going to talk about today are similar for Ewing sarcoma and osteosarcoma. And so osteosarcoma is more common than Ewing sarcoma, also occurs in patients less than 20 years of age, but then it also occurs in adults. So there's a second peak of incidence, which Ewing sarcoma does not have. And then chondrosarcoma, which is the third most common bone sarcoma, is very rare in children and is more frequent in adults. So the age of presentation varies somewhat between these three tumors. And for some reason that is not really understood, is that it's less common in people of African, Asian, and Native American descent. So the diagnosis of a Ewing sarcoma clinically is not specific. They usually present with a fairly large soft tissue mass and pain, but any sarcoma can do that. They tend to have larger soft tissue masses than osteosarcoma, but that's not a hard, fast rule. Occasionally, patients can have fever and weight loss and look sick. And one of the things to understand about a bone sarcoma is that patients usually aren't sick, if you will. And most of the time, patients with Ewing sarcoma are not sick either, but occasionally they can be and present with systemic symptoms. You seldom see that in osteosarcoma or chondrosarcoma. They weaken the bone because they destroy it so rapidly, and they may present as a pathologic fracture. If they're in the spine, they can irritate nerve roots and have sciatica-like symptoms. There are no blood tests for any sarcoma, really, but LDH is often elevated and is associated with a poor prognosis in patients that have a high LDH. And although you would think path fractures would be fairly common, they don't. Usually the pain in the mass gets the patient to the doctor before that happens, but it certainly can happen. And so here's a typical X-ray of a Ewing sarcoma. It's what we call permeative, which means that these little round cells start in the medullary cavity and they grow through vascular channels in the cortex, the Haversian systems, and the canaliculi. They grow between trabeculae of bone in the marrow cavity, and they grow rapidly enough that they don't destroy all the bone in its presence. So it's not what we call a geographic lesion, that is purely lucent, because that implies usually a more slow growing tumor. This thing just zips along almost like an infection through the bone. It's usually associated with a large soft tissue mass, which you can see on this plain film. And this is a Codman triangle, which can occur in a lot of things. We typically associate with osteosarcoma, but you can see it in infection. You can see it in any rapidly growing tumor, and that's periosteal woven bone, so not tumor, that is arising in response to the growth of this tumor, almost trying to wall it off, if you will, but it's incomplete, and that's why it sort of ends right here, and you get this triangle appearance. And then for some reason, Ewing is associated with what we call onion skinning, and you can see here that this is layers of periosteal new bone that's been laid down almost like the skin of an onion. And why that happens, I don't know. Whether the tumor has various phases of growth, and it'll grow for a while, the host responds, it grows again, the host responds, and you get this layering. I don't know that anybody actually knows what causes that, but it is often seen in a patient with Ewing sarcoma, not always this blatant or evident. And then we talked about the soft tissue mass. So if you had to keep in mind what Ewing sarcoma of bone should look like, this would be a good picture. This is one that really shows the permeative features nicely, that is just zipping along, eating up the bone a little bit, but you can still see the residual cortex, and it's permeating through the in between the trabecular bone. This one has a pathologic fracture. You can see there's a large mass here, and you get the sense that there's a soft tissue mass as well. So all the features of malignancy: it's large, it's destroying the cortex, it's not well marginated. On a benign tumor, the host tries to form a mature rim of bone around a benign tumor. This one is growing rapidly enough that the host doesn't have enough time to do that, if you will, and then you have this soft tissue mass. The thing that is important to recognize is you may not see the soft tissue mass on the x-ray. So here's something obviously concerning. Something's eating away. This is the femur, lesser trochanter here. So this is kind of a lateral, and you can see the posterior cortex is being eaten away, and you might not think too much of that. You might not even see it well on an AP film, but then when you look at this MRI, you can see there's a huge soft tissue mass. It's involving the medullary cavity of the bone. It's destroying the bone. So the same features we just saw on the plain x-ray, and the MRI is probably our most helpful test to learn about the extent of the disease. It doesn't necessarily give you the diagnosis, but it's helpful to know how much of the normal tissues are involved, and it helps in surgical planning. A special case is the pelvis, and plain x-rays of the pelvis are fraught as far as diagnosing any tumor. So if you look at this, you might say there's really nothing going on. Some people might focus on these radiolucent things, which is just bowel gas. But if you look carefully, this bone looks pretty normal. This one's being eaten away a little bit. It's just not quite normal, but it doesn't look that bad. And that's because the pelvis is shaped like a bowl, and then it's tilted. and then you're shooting a plain film through it, and the sacrum's actually coming out almost perpendicular to the floor. So it's very hard to make diagnoses on plain films of the pelvis alone. You need special studies. So in this case, an MRI shows this huge soft tissue mass that you probably wouldn't have anticipated by looking at this plain film. So if you're worried about a lesion in the pelvis, you need some sort of 3D imaging, either an MRI or a CT, and that's going to be much more valuable than just a plain X-ray. And so when you look at an X-ray and you see a permeative lesion like this, the things you think about are osteomyelitis, which is much more common, and you'll see it obviously a lot more commonly, and it can destroy bone similar to a Ewing sarcoma. One of the things I learned a number of years ago when I saw a patient that I thought was going to have a Ewing of the humerus, and for some reason he had an X-ray from 6 or 8 weeks prior that was virtually normal, and then when I'm seeing him 6 weeks later, it's mostly destroyed. Tumors don't destroy bone that rapidly, but osteomyelitis will. So you always have to think about that. And we always used to say, if you do a biopsy, you always get a culture, and if you do a culture, you should always have a biopsy. We talked about Langerhans cell histiocytoma that can produce holes in bone. It doesn't usually have a soft tissue mass, but it may. And if you get an MRI, you will see a soft tissue edema around it. So often they're referred in as Ewing sarcomas, and it makes us happy if we can do a biopsy and show that it's eosinophilic granuloma or Langerhans cell histiocytoma and not a Ewing. Osteosarcoma sometimes doesn't make a lot of mineralized bone, so it may look permeative and radiolucent like a Ewing does. Lymphoma can be identical, and it's a tumor I often forget about, so you always have to keep that in the back of your mind, and it can occur at any age. And then there's some undifferentiated pleomorphic sarcomas, what we used to call MFH, that can look like a Ewing sarcoma because it doesn't make a matrix. So these are the things that might be on a differential diagnosis list from looking at the imaging studies. When you look grossly at Ewing sarcoma, and this is probably, I think this is the gross specimen of that humerus we looked at a few minutes ago, it fills the medullary cavity with this fleshy whitish tissue, which is what all these round blue cells are in. You can see it's eating away the cortex here. It's extending through the medullary cavity and usually ends fairly abruptly, and you can tell that on the MRI. And it extends out into the soft tissue. There may be what we call a pseudo capsule around it, but it's not a true capsule, and tumor cells can extend beyond that. Here's one of the femur where there's been a pathologic fracture, and you can see the soft tissue mass that's quite extensive, and that's typical of the kind of masses you see. We tend not to see specimens like this anymore because most patients now will get preoperative chemotherapy. I think we have these two specimens because of the pathologic fracture, so got a resection before chemotherapy. And here's our friends, the small round blue cells. And there's nothing particularly characteristic about this. There are these little white bubbles in the cytoplasm, and those turn out to be glycogen. But you can see that in other tumors. In the old days, we used to do what was called a periodic acid shift, or a PAS stain, which stains for glycogen. So these things would turn up red on a PAS, but nothing particularly characteristic about these. And so the pathologist will not often make a diagnosis on just H&E slides alone. And this is obviously worrisome for a malignancy, but it could be any of those round cells that we talked about. Here's another patient with similar cells, but in this case, it's forming these little circular things, or what we call pseudo rosettes. And that was associated with neuroectodermal differentiation, and that's why this entity called PNET was included in the differential, and we used to try to distinguish the two, but since they have the same translocation, we think of these now all as one tumor type. So what the pathologist is going to do when he or she gets the tissues is they're going to look at it under the microscope, obviously. They're going to do immunohistochemistry, a whole bunch of stains to try to exclude other round cell tumors. We don't tend to do electron microscopy anymore, but that would show the glycogen. And then they're going to do something to look for the translocation, the most common being 1122. And that's often by fluorescent in situ hybridization. Tumors that are more confusing, they may try to do a wider panel of genetic testing. And so here's the characteristic stains for Ewing sarcoma. They're CD99 positive, so all this little brown stuff that you see is showing that these round cells stain for CD99. And then Fly1 is part of the translocation, so the nuclei stain for that. And they do other things too, but just to give you a sense that this is how they sort a Ewing sarcoma out from the other round cell tumors. Ewing is one of the tumors that has a translocation. It was one of the first ones that was recognized in bone tumors, and it's a translocation between chromosome 11 and 22, and the genes that get mixed around are EWSR1 and Fly1, and that's about 80% of the Ewing sarcomas. There's a number of other translocations you don't have to worry about. There are some Ewing-like tumors that have different translocations, sort of beyond the topic of this talk, but finding this translocation is the best way to know that you're dealing with a Ewing sarcoma, and our pathologists rely on that a lot. And these result from a fusion of oncoproteins that then makes an aberrant protein that's a transcription factor and gives the Ewing cell a growth advantage over normal cells. You would think that knowing that, we'd be able to come up with some excellent therapies that would target that and cure a patient with Ewing sarcoma, but so far we're not there. So once you do the workup, we'll talk about in a minute, you need to get a biopsy, and this is where you rely on your MRI or CT scan, because you want to plan the biopsy carefully. And we don't do many incisional biopsies anymore, although that's all we used to do. But if you don't have the availability of core needle biopsies, you have to think about, how will I treat this patient if it turns out to be a bone sarcoma? So you, in your mind, you look at the staging studies and say, this is what I would do to take this tumor out. And if it's on the thigh, you know, maybe a lateral or medial incision. And then in the OR, when you're doing your incisional biopsy, you sort of draw that incision out and then place your biopsy along that line of the expected incision. And you try to do as little dissection as possible, straight down to the soft tissue mass. You don't have to go into the bone if there's a soft tissue mass. try to avoid contaminating neurovascular structures and contaminate as few planes as possible. And you get some tissue for the pathologist. If you have the availability of frozen sections, it's not a bad idea to do that just to make sure you have diagnostic tissue, but you're not going to make decisions on the biopsy because of what we were just talking about. They have to do special stains to come up with a definitive biopsy. So we used to do a lot of incisional biopsies. Now we work with our radiologists, and they do core needle biopsies, either under ultrasound or CT imaging, but with the same principles. You want to know where the incision is going to be, so you have to know your radiologist or speak with him or her prior to the biopsy. Say, here's how I want you to put the needle, because radiologists can be quite innovative of where they might place the needle in places you would never even dream of. So you want to work with somebody you know, or speak with them and say, here's how you want to do it, because in theory, the core needle biopsy tract can be contaminated with tumor cells, just like the incisional biopsy tract is. And it's debatable whether you need to excise the core needle biopsy tract. We try to if we can, but it's not crucial. Incisional biopsies, you do need to resect at the time of the surgery, because they may have tumor cells through the path that you took to get down to the tumor. So here's an example of a needle biopsy under fluoroscopy. It's usually a trocar type of needle where you get a bunch of cores. You again want to make sure you get enough tissue that the pathologist has enough material to make a definitive diagnosis. Here's an example of a well-placed incisional biopsy, because if you were going to, if the tumor was here somewhere, you would have an incision that goes this way. You don't want to do it this way transversely. You want it to be longitudinal, and that you could easily go around this and take that tract out with the tumor at the time of the incision, resection of the tumor. So the staging, you obviously start with an X-ray, and it's important to get the entire bone. We usually get an MRI also of the entire bone, because you can get little skip metastases within the involved bone in Ewing sarcoma, just like you can with osteosarcoma. The most common place of spread of Ewing sarcoma is metastasis would be the chest. So we get a chest CAT scan at diagnosis to look for metastatic disease. And the second most common site is other bone. So until relatively recently, we relied on a bone scan, which is still a reasonable thing to do. But if you have the availability of a PET CT, we tend to favor getting that because it's a bit more sensitive than a bone scan. And the oncologist, I think they're doing this less likely, would get a bone marrow biopsy just to look to see if there are metastatic cells in the marrow to begin with, although they have fancier ways of doing this now. So when you do that metastatic workup, you'll find evidence of metastatic disease in about 25% of patients. And that's obviously going to lead to a worse prognosis than somebody that doesn't have metastatic disease at diagnosis. Although it's important to realize or conceptualize that virtually everybody, every patient, more than 90% has micro metastatic disease at diagnosis. You just can't find it on imaging studies, because if you just treat the primary tumor, even if you treat it successfully, 90% of the patients will metastasize and die of disease. So we assume that everybody's metastatic at diagnosis, but it's worse if you can actually see the Mets. And that's the reason that chemotherapy has been successful, because it works on micro metastatic disease. So you're sort of catching these little cells that have landed in the lung or the bone marrow and treating them before they make a real tumor. Chemotherapy isn't as great for bulk disease, and that's why we use surgery or radiation for the primary tumor. Other prognostic factors other than metastatic disease, pelvis has a worse prognosis than other sites. Larger tumors have a worse prognosis. Some studies have shown that older patients have a worse prognosis. And more recently, histologic response to chemotherapy. So if you give preoperative chemotherapy and the mass shrinks and the pathologist looks at the resection specimen and there's no tumor cells, that patient's going to have a better prognosis than if there are still viable cells around. In this case, it's more of an all or nothing thing. You either have some viability or you have none, as opposed to osteosarcoma where they grade the response. So here's a patient who had a chest CT, and you can see there's a metastatic lesion here that he may have had others. And then you have to figure out, sometimes it's confusing because there are other diseases that can cause little nodules like this in the chest. But in the presence of a known Ewing sarcoma, this would be pretty worrisome. And then here's the bone scan showing that the primary lesion is hot, and you're just trying to see if other bones are involved. In this case, it wasn't. Here's another pulmonary metastasis. Here's what it looks like on a PET scan. And we usually combine that with a CT that gives us more anatomic information. And you can see the bright orange here is this PET is more of a measure of metabolic activity, whereas a bone scan is a measure of bone formation and vascularity. So this is more sensitive since these are highly metabolic tumors. And you confuse it either with an MRI or a CT. We usually use CT. In this case, it's an MRI. We talked about this a little bit. If you find metastatic disease at diagnosis, the likelihood of survival is much less. If it's just in the lung, they have a better prognosis. We see how they respond to chemotherapy. Sometimes we'll remove the metastases. And there are some protocols looking at whole lung radiation to try to improve the survival. And that probably offers some benefit. There's some studies going on with that. But just to recap, it occurs in about 25%, mostly lungs and other bone. PET's more sensitive, and metastatic disease diagnosis is a prognostic factor. So how do we, as orthopedic surgeons, treat Ewing sarcoma? Well, it's actually not just us, it's radiotherapists and medical oncologists as well. So it's a combination of chemotherapy and surgery. And we usually start with the chemotherapy. And the advantage of that is these large soft tissue masses will usually decrease in size considerably after preoperative chemotherapy. And then as far as treating the residual gross disease, you can either excise it or use radiotherapy. And there's some confusion about this. As far as treating the Ewing sarcoma, surgery and radiation are fairly equivalent. Some people would argue there's a higher local recurrence rate with radiotherapy than surgery, but there aren't any real good studies to know that for sure. The primary reason we favor surgery over radiation is now that patients are surviving, they can get radiation-induced or associated sarcomas in the treated bone. So if we think we can get a negative margin with a resection, we will usually resect them unless we think we don't have a chance of getting a negative margin and a functional reconstruction. And when I started practice in the late 70s, the likelihood of surviving the Ewing sarcoma was less than 10%. It's now up to 75% 5-year survival. So dramatic improvement with the use of chemotherapy as well as surgery and or radiation. The types of chemotherapy has modified over the years, but I can just tell you this is what we do now, and I think in Europe this is the kind of protocol. It's a 5-drug regimen of vincristine, adriamycin, cytoxan, ifosfamide, and etoposide. And I'm not a medical oncologist, so I can't go into the details about this, other than to say one of the recent advances is if they take these drugs and give them 2 weeks apart rather than 3 or 4 weeks apart, that has improved their survival. So that's what interval compression means. They try to get as much chemotherapy in a short time as they can. There's some newer agents coming along the line, since we don't cure everybody with this, and these are being studied in randomized clinical studies. We already talked about this, better prognosis if it's localized disease, if they have a good response to chemotherapy. It may matter what kind of translocation they have and other genetic things, but we're not quite there yet. So the treatment of the primary tumor is either radiation or surgical resection. Both seem to work. It's mainly now treating with resection alone to avoid second malignancies. Radiation is used primarily for large, bulky tumors of the spine or pelvis that can't be resected, although we're getting better at resecting tumors of the spine and pelvis and coming up with reconstructions that are functional. Periacetabular lesions used to be very difficult to treat, but now there's some implants that make that more feasible. If we don't think we can get a negative margin, then we'll often radiate, or if poor function or the patient refuses surgery. It's important to understand that if you treat a patient with radiotherapy, there's no functional consequences, especially in children. You're often radiating growth plates, so they may have limb length discrepancies shown here. You can get recurrences. The biggest disadvantage are these secondary neoplasms that occur somewhere between 5 and 25% of patients who survive the Ewing sarcoma. We never used to worry about this because nobody survived, but now that they're surviving, we worry about this more. So here's a patient that I didn't think at the time, this was back in 1990, I could get a good resection on, so we treated with radiotherapy. It recurred distally, so now this patient's been irradiated, and now we have to go back and resect it because there's no good alternative. But a local recurrence of the Ewing sarcoma is usually a very poor prognostic sign. So we were able to take this out. We found an allograft that fit. Her function was quite good, but she died within a year of this, of metastatic disease. And here's an example of a patient that I inherited after he was treated as a young child with radiation to his proximal femur. And one of the problems is the bone becomes abnormal due to the radiation. So it's very hard to diagnose if something's going wrong. So he had pain, worried about it, worked him up, did a biopsy. All we saw was osteonecrosis, and we thought it was just radiation change. But then he persisted with pain a few months later, got a CT scan, you see this mass, and then we biopsied him again, and this is a radiation-induced or associated osteosarcoma. So we had to do a hip disarticulation. He eventually died as well. So just to reiterate, one of the reasons we try to avoid radiation is to avoid this scenario now that patients survive their Ewing sarcoma. And here's an example of a young boy. You can see the growth plates are still open. Can't see too much on the x-ray other than the cortical thickening here, but the MRI shows this mass. He gets chemotherapy, the mass goes away. We thought we could get a resection margin up here and down here. So that's what we did. We put in this is an allograft and fixation, and that eventually healed. And here he is many years later. The advantage is that he has his own growth plates, so he never got any kind of a growth arrest. He doesn't have to worry about a radiation-induced sarcoma. Here's a young girl that was a bit of a challenge, 2.5 years old, with this big mass. You can see how extensive it was. And she got preoperative chemotherapy. The mass shrunk down, but the problem was, how do you put this back together in a 2-year-old? And you certainly don't want to radiate the humerus in a 2-year-old. So we found, fortunately, a tiny little allograft that we put in there from a bone bank. And that lasted for 4 or 5 years. And now she's been converted to an expandable prosthesis. Now, now we know she's a survivor, and we're gradually trying to lengthen her. Although limb length in an upper extremity is not as important. And then in the pelvis, if we think we can get them out and save reasonable function, like here, we will try to do that. In this case, we could save the acetabulum. So that's fairly easy to do. Ones that involve the acetabulum, we now have custom made or 3D printed prostheses that we can manufacture specific for each patient and put it in there. And I think that's it. So that's a quick rundown of Ewing sarcoma.